Hello, everyone, and welcome to today's session on co-creation in community-based prevention. I am Verna Felipe, ICUDDR Coordinator for Educational Programs and Regional Support. On behalf of ISSUP and ICUDDR, we thank you for joining us. To know more about our organizations, watch webinar recordings, and get access to drug demand reduction related resources, we invite you to visit our websites www.isup.net and www.icuddr.org. A few announcements to make the most of today's event before we start. For questions to our presenters, kindly type them into the questions pane of the webinar interface on your screen. You may send in your questions at any time during the presentation, and our speakers will address them during the question and answer session. Webinars and online events delivered and hosted by ISSUP and ICUDDR are provided for informational purposes only. A recording of the webinar will be available for you to watch on demand after the event. Over the years, we have seen an expansion of community-based prevention. Today, our speakers will highlight community empowerment through different intervention phases. In this webinar, they will discuss the challenges of community-based prevention and share tips on how to use of local data that leads to better outcomes. We are privileged to have with us Dr. Ina Koning and Dr. Samuel Tomczyk. Dr. Ina Koning is an Associate Professor of Clinical, Child and Family Studies at Vrije Universiteit at Amsterdam. In addition to her research on parenting and the prevention of adolescent substance use and problematic online behavior, she has made a significant contribution to research on youth risk behavior in interaction with the social context, applied to both substance addiction as well as behavioral addictions. Currently, she is the principal investigator of the evaluation of a community-based intervention targeting substance use and mental health in Netherlands. She highly values the transition of her work to practice and has a history of disseminating her work to utilize the knowledge gained in the most comprehensive way possible. We also have with us today Dr. Samuel Tomczyk. He works as a junior professor for digital health and prevention at the Institute of Psychology, University of Greifswald. In his research, he examines the requirement and impact of digital technologies in prevention and healthcare, with a focus on digital mental health, substance use, and child and adolescent health. He utilizes mixed methods and participatory research approaches to investigate co-production in the development, implementation, and evaluation of digital health and prevention technologies, including digital communities. Ladies and gentlemen, with much pleasure, please welcome Dr. Koning and Dr. Tomczyk.
Thank you very much, Verna, for this elaborate introduction. Thanks a lot. I'm happy to be here. Thanks so much for the invitation. We are going to talk about co-creation in community-based prevention. Indeed, as Verna already said, and you signed up for this workshop knowing that, of course. Let me check. So, first of all, for those who can only stay for a few minutes, I always like to start off with the take-home message. And in this case, stakeholder engagement or co-creation or public engagement, however you refer to it, it should be considered as an intervention in itself. That's what we argue in this paper. So that's the whole take-home message of this webinar already. So we are curious who you are. I can't see you. I can't see anyone. So I'm just talking to my screen. Let's have a small poll to see who you are so that we know better who are listening to us. So If it's correct, you can see the first poll. What is your experience in community-based prevention? Yeah, first this result. Okay, well, it's about 50-50. Half of you have limited or very little experience, and half of you moderate to extensive. Okay, good to know. Thank you. The second one, what is your field of interest? Okay, can we see the results? Yeah, great, thanks. So I do see that it's a combination of interests. Most of you are involved in drug prevention and then mental health and alcohol prevention as well. Okay, thank you. Did we have one more? Yeah. What is your main role in prevention? Okay, let's see the results. I hope. Yeah. Okay, more than half of you is a practitioner, some researchers as well, and other, and a few policymakers. So that's really nice. A very diverse group. Okay, thank you so much. We'll continue. You'll see the take-home message, if it's correct. Let's see, Samuel is taking over from me. So Samuel,
Yeah.
the floor is yours.
Thanks, Ina. Just as a short overview, the first thing we started with is getting to know our audience a little bit. We can't see you, we can't hear you, we can't interact with you very much, but we know a little bit more about you. And this is basically what it is about here, to really get to know your audience, get to know your target groups that you're working with, and see what they need, what they are expecting, or what you can build upon, which resources are already there. So what we plan to do is to present a few key definitions of key terms that are important in the field of co-creation and in community-based prevention. Then we will look at examples from the literature and also an applied example, which Ina will present in more detail, a project that she's been working on regarding community-based prevention and the processes of co-creation that she used. And then we will end with a few tips and tricks that you can maybe take away regarding the integration of local data, but also the implementation of co-creation in community-based prevention. As we all know, there might be a gap between science and practice, and those of you working in practice probably already know that there is not enough time to include science all the way and every time, and those working in research know that there is a long way between doing research on a certain topic and implementing it in practice as it was intended. So what we can do, or what we try to do, is to use processes like co-creation to sort of address this gap and look at what we can do. For example, a stratified or a strategically planned needs assessment that we can do to be informed on practice needs, on the importance there, and then we can help in defining strategic planning, usually science and evidence-based, and to have a few steps and processes in place that can help and support the process. There are many factors contributing to this gap. This can be different backgrounds of people. They have different expertise or education. They have received different training. They have different types of experiences. We often work with different disciplines in the field of prevention, be it social work or psychology or medicine or whatever, criminology, depending on the field that you're in. But if you work in drug prevention mostly or mental health, then you know that there's a lot of intersection of different experiences, also perspectives on what prevention actually means, what is prevention not. There are different limited resources that have to be allocated and things like that. So there are many different topics, and we can't address everything all at once, but we can sort of prioritize. And if we look at community-based prevention, what makes it so special is that we The idea is to look at community as a setting or as a specific setting. It is not only where the research takes place or the development might take place, but also the implementation, so the intervention within the community. We have to pay attention to the processes and the particularities of this community, of the target groups in the community, and we also have the effects within the community. So we can look at, of course, epidemiological data and things like that, but we can also look at other data, other outcomes based on the community, which might be more specific in some cases. So this is sort of a balance between the general traditional approach to prevention, to evidence-based prevention that we know, for example, from evidence-based medicine, but also take into account the aspects of the community that may play a specific role here. And for us, one step to do that is to include local data. And just as a brief definition, as I mentioned, local data refers to any data that is collected by local authorities or other bodies, for example, higher education or research institutions in your area, and it represents relevant conditions on a local level. And these can be quite varied. These are just a few examples that we've provided for local data. So you could look, for example, at the density of housing or the type of housing in residential areas. You could look at the density of nightclubs or bars and what they are next to, how they are accessible to people, how many green or blue spaces are available, how accessible are they to different types of populations, for example, families. You can look at specific zones, for example, restricted zones or restrictions that are in place, how you can use that in your preventive efforts. And then you can also use other data, which would be more about, for example, public opinions. There are certain surveys, for example, regarding political opinions, political surveys that you could use to be informed about attitudes of the populations. And you can also look at their activities, for example, participation in sports or in other groups. So how many are they used? How frequent are they being used by different groups? Or families, how many families are there in different areas? So there's a lot of data available on a local level that you can access and that you can connect to your research, either regarding the needs assessment, or if you look at the implementation or evaluation, which target group you want to reach, which factors you want to address, and things like that. And then, of course, co-creation. It's already in the title, and here it is already. Co-creation as a process to plan and define services, public services aimed at reducing the mismatch between beneficiary needs and provided services. It is particularly useful with IT tools when you use them, because you can use them to easily get people involved and have them across the globe, as we do right now. We have a webinar where people from many different locations can participate. And in co-creation, the important part is to really listen to your audience, look at them and see what is important. So for us, and this is on the next slide, the idea, if you look at how you implement co-creation, we have a lot of strategic planning that we can do, that probably all of you do already. We have evidence-based knowledge, what works, what doesn't work. We have different interventions or approaches that we can talk about. We have monitoring tools that are implemented. But the important part is to really match it closely to the needs of the local population. This is done through co-creation. So you can really think about working together, co-creating interventions. You can co-create plans for interventions. You can co-create or development interventions, implement them, and the evaluation as well. And Ina will go into more detail on that later. For now, we want to introduce two examples or exemplary approaches that make use of local data, that are basically stakeholder-driven, so co-creative, and that utilize the community-based prevention framework. And these are the communities that care approach that some of you might know, and the Icelandic prevention model that some of you might also know. We will introduce them shortly, but for now, we have just a short overview of the program. So communities that care, so far as a program, is mostly implemented in the US, in Australia, and in some regions in Europe. The scientific evidence is good for the connections between mechanisms of change and the outcomes. So there are different processes being described and evaluated, and there are also effectiveness studies. There's a registry of evidence-based prevention strategies that is necessary for the approach. The Icelandic prevention model, on the other hand, is also widely implemented in different regions across the world, but so far there are not studies that are clearly linking the implementation mechanisms and outcomes, and there are just very few effectiveness studies available. A registry of evidence-based prevention strategies is not needed for this approach, and we will look at it in a minute to see why. First of all, communities that care as an approach works in a 5-step process. This is a very easy description of the process. To get started, you have to form a community coalition. So you have to identify who are key stakeholders in the community, who are responsible, who have something to gain or something to lose from this process, who are involved, who can make changes. You have to get them together to form this coalition, to do some team building. They have to identify a community profile, meaning strengths and weaknesses in the community, things that they want to work on. They have to create a plan on how to address it and select evidence-based prevention strategies to implement, and then they have to implement and evaluate them. So the key part of communities that care is twofold. There is an individual social development strategy model. You can see on the left-hand side, just a quick description here. It considers individual characteristics, for example, in adolescence, their personality or their risk behaviors and their socio-demographic data, their family status and things like that. And then it plans to build relevant skills and recognition for their achievements that they have, and also provide opportunities for positive social development. The idea is to form positive bonding with the community, to form healthy attachment, which leads to healthy beliefs, standards, and behaviors. And on the right-hand side, there's also a process described on the community level, which means that the community coalitions are adequately trained, they have enough resources, they know what evidence-based prevention science is and how to apply it to their daily work. And both of these processes have been proven over time, so there were many studies addressing them and seeing that they are effective. And one use, this is an example, the evidence-based exchange prevention registry, which collects and reviews preventive programs and then makes recommendations on the evidence base, whether it's good evidence, so there are many high quality studies supporting the program effectiveness or not, what the areas are that they have been tested in, and further questions or things that are of importance. So if you're not already working with prevention registries, we can recommend you do so, because this is scientifically proven and there are a lot of people with a lot of expertise behind it that are really taking the time. There are similar registries in different countries, so depending on your country, you can also ask, for example, the EMCDDA or the exchange team to just give you some recommendations for other registries as well. And then the second model, we have the isolating prevention model, which is also known as Planet Youth as an approach. And we can see here it also focuses on an individual in their context. So the idea is similar to communities that care. We look at communities, which includes families, peer groups, leisure time activities, and schools, of course. And the idea of the model is to also work with these communities. So the approach is a bottom-up approach. They use a lot of recent and local data. So they use a lot of different data sources and multi-component information to address youth behaviors, for example, alcohol use in communities. And they are interested in looking at evidence-based mechanisms, promoting positive behaviors and activities, and lowering drinking opportunities, for example, through curfew hours for young people. But what they do not have is as an elaborate model as we saw in the communities that care, and an evidence-based registry behind it, and also the studies supporting these mechanisms. What we do know from the studies, this is what Ina now presented, is that there is an effect. So there is an impressive effect of the Icelandic model in Iceland, which is great. So Iceland, yay, good job there. But what it does not say is how this actually was done and how it is comparable across different settings and countries. And this is where we want to be attentive and be cautious when looking at the results. So for communities that care, for instance, we know that there are effects across different communities. We have similar measures implemented. We know that effects can be similar. It's not the same for the Icelandic prevention model yet. So there is a promise in some of the strategies and approaches they use, for example, how they integrate local data, but there are also challenges because the conditions are very different from a smaller country like Iceland compared to other countries with other systems, which may be more complex or maybe more varied in certain areas. So there are a few points of criticism or concerns that we have raised that were discussed in the ISSUP in a position paper, which Ina was also an author, a lead author of. So this is something just to keep in mind. Both approaches are promising, but they have different challenges that they bring with them. And specifically, the lack of science or scientific studies in certain areas is of importance in the Icelandic model. So much for theory, I guess. Then now it's time to hear a little bit more about practice and how it actually might work. So back to you, Ina.
Thanks a lot, Samuel. This helps. This helps. I will, as Samuel says, I will provide an example of a community-based alcohol intervention, which was inspired by the Icelandic prevention model, but we added a little bit of evidence-based knowledge and the evidence-based strategies to this project. We conducted this study in the Netherlands. We set up a quasi-experimental design. So here we had one community wherein we developed and implemented this intervention, and we had a control community that did not do that. This program is referred to as LEF. You can take a look at the website, but it is in Dutch. But let me know if you want to know more about this. This is what we did. So I simplify things just to make things work and to get the message across. So first of all, we go through these activities step by step. So don't worry. But this is the overall model. So first we had an inventarization of the stakeholders who are relevant if we want to change the drinking behavior in youth, underage youth. So therefore we held interviews. I held interviews with many different stakeholders, youth themselves, parents, but also policy makers, bar owners, with many different people, because I had to know what is going on, what is their view on this drinking behavior in the community. We also, so as a part of the needs assessment, we also conducted self-reported questionnaires in the high school, just to also get some numbers on, okay, but how is there a problem at all? Because perhaps the municipality may feel that there is a problem, but when you look at the numbers, it's not a big problem at all. So what are we going to focus on and why? So based on these two types of data, we defined the desired outcome. And that's the behavior that you want to change. So based on the desired outcome, we looked at, okay, what are important determinants of behavior? So what are changeable and important factors that we know from science contribute to this desired outcome? So they need to be changeable and they need to have a priority. So supported also by the data following from the needs assessment, so that people recognize, yes, this is relevant. For example, parents are really important here. I'll get to the determinants of behavior later as well. So based on the selection of these determinants of behavior, we developed an explanatory model. So that visually shows how are these factors interrelated and how do they contribute to the desired outcome. Okay, once that is developed, we go to the next step, and that's the selection of intervention strategies. And that's where we also applied even more, because we did that already before, but we worked together with the people in the municipality to see, okay, what is needed, which type of strategies would match this community, and is also feasible for you to work with. We also looked at the existing local intervention strategies, because for reasons of sustainability, I believe that it is important to also look what is already being done and which organizations are already working on this topic, and can we collaborate with them, and add, of course, the scientific knowledge. So let's go to the first step, the inventarization of stakeholders and the needs assessment. So why this is relevant? Why is it important to assess these needs? First of all, it's really contributing to the understanding of what is going on. So in with respect to alcohol use, why do people at all feel that this is a problem, that it should be addressed, and why would they, and why wouldn't they also? Because some people may also be against it. So what is the public opinion about it? Well, you have to take that into account if you want to change the drinking behavior in youth. Also, it helps you to make decisions about priorities. You cannot do everything all together. So changing the drinking behavior is already too broad. So which specific aspect therein do you want to change? So make decisions about priorities, and also later on, for who are you going to target? You cannot do everything all at once. So that's why this needs assessment is really important. So what we saw here, from in the needs assessment, from the self-report data, we have on the left side the prevalence of monthly drinking, on the right side prevalence of weekly drinking, and each bar depicts a different age group. So blue is 12, red 13, green 14, and so on. So for the prevalence of monthly drinking, as well as for weekly drinking, we see that there is this huge increase from age 13 to 14. So knowing this, it is important for us, if we want to prevent the onset of drinking, to already implement and start intervening before the age of 14. So this is also a way how to use the local data, so that you get a better insight into, okay, but if we want to prevent a certain type of behavior, when do we need to intervene? When is prevention possible at all, depending on your outcome? So here we decided that it should be implemented before the age of 14. Also, what we did is we compared our data, so that's the left side, to the national data, just also to know, but is this a problem? Is this a challenge for this specific municipality, or is it a Dutch issue? Because that also matters in the kind of the framing and the understanding of this issue. So again, all the different age groups, and you see this for monthly drinking. And when we compare this to the Dutch data, this was done in 2018, and there was also recent national data of the HBSC study available. So we were lucky for that. So comparing this, we concluded, okay, yeah, it seems to be, there seem to be more drinkers, underage drinkers in our community compared to the Dutch average prevalences. So making a point and helping people to see the relevance of this, you can use these data for that. And also to get political support. All right, knowing this, then where to start? How do we co-create? So just an example of how we did that. It's not said that this is the only way. There are many different ways. So please take that into account. So first of all, we created public support, because in this municipality, there was a lot of resistance against this type of intervention. Things like you were young yourself as well, and you turned out pretty good. And also you're taking away and fun, enjoying youth of these kids. And we're prohibiting everything, and they should just be allowed to drink. So there was a lot of resistance against even discussing the change of drinking behavior. So what we did, first of all, is we gained some media attention. So we wrote there were some articles published in the local newspapers. We also held presentations at the council meeting to get political support for this. So that was really important for us to do first. However, so we wrote information letters, we had these think tank meetings where everyone was invited, and we had this core working group consisting of people from the municipality, important stakeholders. So what was a challenge here, I indicated that at the bottom, is the balance between keeping an eye on the evidence-based process, and at the same time, when having these think tank meetings, the enthusiasm and more activity-oriented members that were there. So many people who showed up, they were like, yeah, I can do this and I can do that, and let me do this. And we're like, no, this is just a part of the needs assessment. Still, it was the very first step to create this public support. So first, we need to figure things out. And we are interested in your opinions on this data, but no activity yet, because we wanted this intervention strategy to be matched to the factors. But we were now still looking at these factors and creating support to change, to implement anything at all. So that was a challenge. We also created public support among the local politicians. Well, what helped here was the use of the Icelandic prevention model, because as Samuel already said, there was this hype also in the Netherlands for this model. So our politicians also were part of that. So I used that to get them on board and to get their support. I also held a presentation every three months in a council meeting, because we needed to keep that support, and we needed them to feel taken seriously, because that's the key here. The politicians were also members of the think tanks, and what they highly appreciated was also inclusion of research, so the monitoring, and that's what we did. Here the challenge was finding the balance between planning ahead. That's what politicians' needs are. They want you to be very explicit and clear about what are you going to do when and how much money is involved in that. And we were like, yeah, but we don't know. We're not sure yet. It depends on this and that and this. So that was a challenge there. Okay, the next step. Identifying the determinants of behavior. So we need to target the youth before the age of 14. It was about underage drinking, and we wanted to prevent the onset of drinking or delay the onset of drinking. So age of onset of alcohol use is then the outcome, the desired outcome that we wanted to change. And these are the different determinants of behaviors. So the different factors. This is based on the interviews as well as the quantitative self-reported data as well as science, because we know already a lot. So we're not going to think of everything ourselves again. We know a lot about important mechanisms of change. So the societal norms, these influence also parental norms about alcohol use. And I added here the perceived peer pressure, because what we saw and what we found out in the interviews, and we would never have known that if we would not talk to these parents, is that these parents perceive a pressure of other parents to be more tolerant, to provide alcohol, to let kids organize parties at their home. So this was an important aspect that we had to take into account. So these norms are related and influencing the rules about alcohol. That is related to the level of self-control, and that to the age of onset. Kids with a lower level of self-control are more likely to drink at an earlier age. This is the second line, the second process, which is also related to the parents. So the societal norms about drinking is highly accepted in the Netherlands, I think all over the world, in the Netherlands as well, and also in this municipality in particular. With these more favorable and positive norms about drinking, these parents have a lot of social activities themselves. In this particular municipality, it's a very closed municipality where everyone knows each other, and we have the highest percentage of people who are born there that die there. So people stay there. They don't move out. So not many of them. So everyone knows each other. It's a Catholic village with large families. So every week there is a reason for the party. So these social activities of parents are important in this local context. That influences the level of parental monitoring. If the parents are away from home, then it's more difficult to know what your child is doing. And monitoring, we know that's also related to the level of self-control. Then there is this third process that we identified, and it relates more to the kids and their peers. So these are the lack of alternative activities or the lack of a diverse offer of alternative activities. These are related to the norms, because if you do not have that, it's higher likely that you come in contexts where people drink. So there's a greater likelihood that you will develop these positive norms. And if you have that, if you see that, you are also more likely to perceive more pressure from your peers to drink. Depending, of course, also on the level of self-control and also your self-image, it is related to the age of onset. So this is the explanatory model that we identified. And we use this as kind of the foundation for everything that we wanted to do. Every intervention strategy that we wanted to implement, I asked the organization, like, to which factor is it connected? Because some of them are sometimes easy to implement. Some factors are more easy to change, like, for example, the alternative activities. But if all intervention strategies just focus on the alternative activities, then you're just targeting one factor, which is important, of course, but then you're missing out on the process where parents play an important role. So it's also a way to gain better insight into what factors are you intervening on and which ones are kind of left out and do we need to focus on more. So then the next step, and I already talked about that a little bit. So we applied this co-creation and we looked at what was already going on and what do we know from science. So in these intervention strategies, it should be evidence-based, evidence-informed strategies. So that's what my role was, to monitor everything, but also to supervise and to guide this process of development. So I advise them to make evidence-based decisions, which I feel is really important, and to match these to one or more determinants of behavior. So that's the matching of these intervention strategies to one or more factors in the explanatory model. So what we did first in the left program is that we targeted the leisure activities, the alternative activities. What we found out when talking to kids, that there is enough offered in the municipality, but it was mostly focused on sports or music. So kids who do not like sports and who are not involved in any music activities, they were kind of left out. So that's why we focused on a more diverse program with the different, including more different leisure activities. And what we found out in these interviews with kids is that most of these activities were offered not on the risky evenings, so not on the Friday and Saturday evenings, which is for alcohol use considered a more risky evening. So that's also what we increased. In addition to that, it's not in the model, it will be after this, is the level of the visibility of enforcement of alcohol regulations. Parents told me that they really tried to postpone the onset of drinking, to not let their child go to any of the outlets. But they said if they are allowed to go in there and to buy alcohol, then it's rather difficult for me. So it would help me a lot if they could not even buy this alcohol and enter these outlets. So these are the first two things that we did in terms of intervention strategies. So to lower the level of accessibility of alcohol outside home and make it visible also to parents, because they told me that it would support them, it would help them in setting their own rules about drinking. Okay. So then just briefly, I referred to this paper already at the beginning. I refer to it as the pre-intervention effects. So actually without having implemented any very specific intervention strategy yet, we already saw changes. So we conducted this needs assessment in May, June 2018. Then we had this co-creation process, the development of the explanatory model. And by the time that we were kind of ready for the implementation of the first two intervention strategies, so a more diverse leisure activity and the enforcement of the alcohol law, I thought that many things could have happened in between. So in January 2019, we started with the implementation of these two intervention strategies. And that's why we added an additional measure in December 2018, so right before the implementation. And just to know, just to see if I had to take into account any changes in between May 2018 and December 2018, I looked at the changes in the mechanisms. And that's where we saw that there were actually already changes that could be contributed to this co-creation process, as well as the media attention for this program. So if you would like to know more about this, please take a look. I will just briefly, for now, show you one outcome that we saw, and that is the change in norms about drinking. So the green line is the experimental condition, and the red line is the control group. So in June 18 and December 18, nothing actually had happened. So what we see here is that compared to the control condition, there are less positive norms about alcohol use in the experimental condition, while in fact we didn't do anything. And after the implementation of the intervention strategies, we again saw in June 19 that they crossed and that it remains effective. So this is just an example of the change that we observed, also in this pre-intervention phase, the co-creation phase, which highlights the importance. So a summary, because I can imagine that it's a lot of information. When co-creating an intervention, it is important that it is a multi-component intervention, that you intervene across several domains, that you also consult and activate local organizations. Your program will be more sustainable if you do that. I do this research and implement these kind of interventions, well, with an idea of having it there for many and many years, if it is effective, of course. But once the project is over, that's often when programs and implementation of interventions stop. And in order to avoid that and lower that risk, make use of local organizations. Collect feedback on each intervention component, so not just overall, but continuous feedback throughout the implementation of each component. It is important to have it supported by alcohol law enforcement and to continuously monitor what is going on. So what we did in this project is we had these biannual interviews with parents. So every 2 years I had interviews, and every other year I had a questionnaire. We conducted a questionnaire among parents and annual monitoring among youth. So what was a challenge here is the balance between the shared interests of this program when you're working with local organizations and the personal or organizational interests of these local organizations. So that was a challenge and difficult. So we have some tips and tricks. First of all, on co-creation. It is really important to increase your understanding of the context and or population. So think about what are the norms here, what are traditions, what are very specific factors that are relevant in this context. I don't believe you can implement an effective intervention if you do not understand the context. Take time for this pre-intervention process. Monitor over time, so keep track of what is going on across the different stakeholders, and in a quantitative as well as a qualitative way. And as I said already before, make use of existing organizations, structures, strategies, adapt if needed, and then keep the key elements. So based on research, if you could identify what are the key elements in this intervention, then you may change the package around it, because if that is better for you to effectively implement your intervention, then that is accepted. But you have to remain these key elements. And then Samuel.
Yeah, for using local data, it is also important to see what is already out there. So the first step is to really track existing data, or if not, complete or collect new data. Like Ina mentioned, there are several, for example, epidemiological studies on different types of use. You can see whether your region is already represented there or your community, or whether the data is not available. Sometimes it helps to ask, for example, responsible research organizations, and they can do additional analysis of the data. And if it is not available, it can also be possible to collect new ones. The very important thing is to prioritize the outcomes. Also, as Ina said, again, to carefully think about what target group you are thinking about or what behavior you want to address. So in this specific example, it was the age of onset of alcohol use. So it is a very specific outcome that was defined. So this is really important to think about and prioritize in your model. And then also identify the relevant determinants of behaviors. Again, you can take your time for this one, and you can also use different sources of knowledge. The evidence base is always great to look at the scientific evidence base, but also have an integration, a co-creation process here to see if there's anything that is additionally important. Or like Ina said, with the interviews, are there any topics that are not addressed yet or that we feel that might be important? So this is more of a bonus, and you can get more information there as well. And the same thing applies here. It is important to update the data database to see how it goes, to have a sort of a monitoring to see if there are some changes, and have a realistic time frame for that as well. So for example, an annual assessment could be good, even though it might mean some work, but it can be helpful if you look at behaviors or norms, or if there are changes in the laws that are implemented, so you can really monitor these changes and see what the effects are. Okay. So that's it from our side. We thank you very much for your attention, and we are looking forward to discussing a few questions. And as Ina said, if you have any questions or concerns beyond this presentation, feel free to reach out to us.
Thanks.
Thank you very much, Dr. Ina Koning and Dr. Samuel Tomczyk. As a reminder, you guys can still send us the question. I have learned so much. There's so many information. I think I love the fact that you mentioned how when you go and implement projects in the community, you just don't go there and impose, but rather listen also to what they have, the resources, and make them feel as part of the program. While we're waiting for the questions from the audience, I have a few that I would like to ask. So I'm very interested in you guys mentioned that you sent out information letters. So I was wondering, is it a generic one, or you sort of tailor fit it depending to, like, do you send it to parents? You mentioned some policymakers. So how does that work, the information letter?
Yeah, well, it depends on the aim of the information letter. So what we did is we aimed to increase the level of public support. So that's why we had this information letter about the program itself and the process of how we would deal with this. So what is the program? How are we going to work on this? So just very informative about the process of the intervention. So, but it really depends on what the aim is and who your stakeholders are.
And just to add to Ina's point, it's also important to think about the communication channels, right? If you think about the target groups, for example, young people using specific social media applications, it might be useful to contact them there to have a good reach of your audience. But you can send more traditional letters, for example, to households if this is more about older people or families and there's more information for them. So you really have to think about both the content and the way you present it.
Thank you. And then their question are, what are some challenges with implementation of the Iceland model?
Wow.
Just some,
Maybe
Ina.
from your
Not all.
experience.
How much time do we have left? Okay, well, I think the biggest challenge was indeed to get that support, to get the level of support. You need to take time for that. You have to get that right before you can do anything. So that's true for every intervention actually that you want to implement. So for this particular intervention, what I found was difficult was that first of all, the municipality kind of wanted me to implement the Iceland prevention model as it was. And I told them, well, it's not evidence-based enough, and these intervention strategies that are implemented in Iceland do not hold here in the Netherlands. For example, if we ask parents to have these curfew hours in the evenings at 10 o'clock, and parents have to go on the streets and send kids home, well, that's not typically Dutch and perhaps not German either. So that's very difficult to just copy paste. So what was difficult there was to get support for doing different things. That's one thing. Another one is then also to think about, and I talked about that already, to find the balance between the very great ideas of local organizations and the scientific evidence for these type of strategies. And so that was also a huge challenge. So how can you keep them motivated for not always the intervention strategies that they have come up with? So that was difficult. And I think you can only deal with that and by taking them seriously and by keeping them involved and explain why you do not go for option A, but that you feel option B is better. So you have to make them part of that process and not just come back to them by the time you have developed something. Samuel, anything to add?
Well, I think these are wonderful points. If we look at it as a co-creation, as a participatory process, they really have to be part of the process and part of the decision-making process as well. It's not the best way to just include them as more passive participants who are just informed about the decisions, or you say, well, this is science or evidence-based, this is what we do, or this is what you want to do, but they should be part of the decision-making, I guess, is the thing here, and to have a good balance of including them and their experience, but also pointing to the challenges or the limits when it comes, for example, to evidence-based strategies versus experience-based strategies.
Yeah.
Okay, thank you very much for that. That answers a lot of the questions that we have in terms of context, advantages, and disadvantages. And for we have a question with regards to the funding. What were their funding implications in order to provide more out-of-hours activities for young people? So maybe is this funding from the government or a civil society who implements this out-of-hours activities?
Yeah, that's in our case, that's funded by the local municipality. But because they have included these local organizations that already received some subsidies for organizing these things, that's at least what we have in the Netherlands. It didn't cost much more, just a little bit actually. So they tried to find a way together with these local organizations. So first of all, to make their offer of the program of the activities more diverse. It's something that they could do already without any extra costs, but just make a more diverse program. And then some additional, for the additional activities, they received some extra funding.
Okay. I think we still have time for a few questions. There's a question here about, and this is quite challenging, but it's very, it's the reality for most places. So what about situations where there are political interference regarding the community needs versus political interest, but you are sort of forced to do what's not necessarily beneficial to the community? So how do you navigate that challenges?
Samuel, you want to go first?
Well, I mean, we don't have that much time, I guess. So it's a very important question, and it's one that Ina had also mentioned in parts, that there are these different interests, and it really depends on the situation. Of course, you don't have endless influence in what you do. You don't have a reach that goes everywhere. Some people may be open to discussing things, others may not. Some things may be changeable, others might not. So for me personally, I don't think there's an ideal strategy to deal with these situations, but a very important one is to really reflect on it, first on yourself or with your team, to see what are the challenges we have, what can we address, what is maybe something we should address at a later point in time. And also, like Ina mentioned, I think it helps building an explanatory model, not only for the target behavior, but also for your process as well. So it was a bit of the part that I introduced with the communities that care approach, to think, what does this community need to get there, to get to this point? And we can also identify if there are a few agents that are totally opposed, on what areas do they have influence, and how can we reach them? How might we address them at some point, to really think about what could be mechanisms that could help us. And there are a few examples where this helps. So really build a core team that is a proponent of the approach, that works together on this, that thinks it's a positive approach, and be consistent with that. And then over time, it can help, because if there is some movement, if there's some improvement, if there is positive press on that and things like that, and people are, then also people who might be opposed in the beginning can come around and see the benefits of it. So this would be sort of my suggestion, to have sort of a similar process on the project level, and think about the teams, the processes, and how you can address them.
Yeah, and important herein probably is also to identify some important key stakeholders.
Mm-hmm.
Some people that you know of are really important in the community, that if you have them on board, it helps a lot. Or the other way around, if you do not have their support, things will be very complicated. So that's something you have to also think about before you start this whole process.
And with that very difficult question, right? So there's needs, resources, priorities, and identifying like some sort of a focal point that could be the mover or breaker of such prevention programs. So we're about to end, and I'd like to thank our speakers, Dr. Ina and Dr. Samuel. So you have been an invaluable source of information. We also would like to thank ISSUP staff for providing technical support, and all of you for attending. We hope you learned something new and enjoyed the presentations. You will receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. We appreciate your feedback and suggestions. Please use the link in the follow-up email to fill the feedback survey. Again, thank you very much and have a great rest of your day. Thank you.
Thank you very much.